Welcome, everybody. If you could take your seats, I'd be very grateful. Well, it's my pleasure to welcome you to this public session of our committee. I'm delighted to be able to host the first part of it, along with my colleague, Sayan Ishtar. This is a session in which we'll be hearing from the sponsors of the study that will be done by the committee here assembled. First of all, let me just begin by thanking the sponsors. There are no studies without can't go ahead without sponsorships. So to USAID, NIH, PEPFAR, the Wellcome Trust, Imperial College, Medtronic, Johnson & Johnson, who are the study's sponsors, I just want to express my personal thanks, the thanks to the committee, and the gratitude of the National Academies. Representatives from Wellcome and J&J are unable to be with us, but we have others, both virtual and with us in person. Now, this is a public session of the committee, which operates under rules of openness, and everything's being recorded. One of the rules is I need to read you a formal statement, which I apologize for, but it's informative about the terms of engagement over the next few hours in public session. So as co-chair of this study and of the committee meeting, I've been asked to let everybody know that this is an open, on-the-record information gathering session. The committee is in the process of collecting information and materials that it will examine and discuss in the course of making its findings, conclusions, and recommendations. This is, of course, our first meeting. Therefore, I ask everyone to be mindful of the fact that this committee has made no conclusions, and it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals here today, including members of the committee, should not be interpreted as positions of the committee or of the National Academies. In addition, the committee members are asked and expected to ask probing questions in these information gathering sessions. These questions are for information. They may not be indicative of their personal views. This is the first of 4 planned committee meetings. The second meeting will be in early December, and it will also include a public session where we'll have more opportunity to hear from more experts in the field and receive public testimony. This committee will be deliberating thoroughly in writing a draft report. That draft report is currently planned for release in August of 2018. We'll try to stay on schedule. Once the draft report is written, it will go through a rigorous review by experts who are anonymous to the committee, and the committee must then respond to this review with appropriate revisions that adequately satisfy the Academy's Report Review Committee and the National Academy of Sciences president before it is considered an official Academy's report. I'd like to also give some guidance on the format of today's meeting. What we'll do first is have a chance to hear from some of the sponsors on their priorities for the study, the areas of focus within the Statement of Task. The Statement of Task is our guiding document that charges the committee with its work. Following discussion with the sponsors, we'll take a break, and then we will have an additional background and context on healthcare quality methods and approaches with other speakers and panelists. And before adjourning, we will have an open public session for a public input. So anyone that wants to speak up to us, we welcome your comments. We have spent part of the morning reviewing the Statement of Task, which is long and excitingly detailed. We are being asked to examine, among other things, particular prospects for improving healthcare quality while expanding access to preventive and therapeutic services globally with a focus on low-resource areas, which is our focus, but not our exclusive focus. This study will put emphasis on the organization and delivery of safe and effective care at the patient-provider interface. So we will be commenting on policy and higher-level issues, but also addressing the care itself. Dimensions of care that we will be considering in the committee, according to our charge, should include access to services and commodities, effectiveness, safety, efficiency, and equity. The focus will be on frontline service delivery that can directly impact health outcomes for individuals and populations. We spent the morning reviewing the charge in great detail and clarifying our understandings. And with the sponsors, we look forward to dialogue with you, where you help us clarify your intentions with the charge. And we actually have some very specific questions for you. A few reminders to the audience. In the interest of time, the speakers will be introduced. I'm not going to do an elaborate introduction, name, title, and affiliation, and the more detailed speaker biographies are available in the materials that have been distributed. During the Q&A questions and discussions, the committee questions and comments will take priority, and if there is time remaining, then we will invite others not in the committee in the audience to ask questions. This meeting is being both webcast and recorded. The available speaker presentations and the video of the meeting will be posted to the project website very soon after this meeting. And further information on this study and future meetings I will mention to you can be found on the project website. There'll be open access to that. So I'm going to now have the pleasure of introducing our first set of speakers who will represent the sponsors and talk about the charge to the committee. My request of you is that you briefly introduce yourself, a little bit of your background, general, your expertise, your affiliations, your prior work, just so we get to know you a little bit better, and then the floor is yours. We have now 1 hour and 15 minutes for this segment. That allocates each of the 5 speakers will have 15 minutes. I'm going to be a little bit severe about the 15 minutes, and you get gold stars for less, and we'll try to please hold you to those times so everyone has the time to do it. Are our telecom and video members here? So I'm going to begin with Katherine Wales from Medtronic Foundation. If you're on, can you hear me, Ann? And are you on?
I can hear you. Yes. Can you all hear me?
I can. So Ann, please introduce yourself and set the tone. Thank you very much for your support and welcome your comments.
Perfect. Well, thank you all, first of all, for having me, and I apologize that I'm not there in person. I also recognize listening to somebody speak on the phone for 15 minutes is not that fun, so I will try to keep my comments a little bit shorter. I'm stepping in on behalf of Purvi Bhatt, our Director of Global Health at Medtronic Foundation. She couldn't be here today, but I'm happy to speak on behalf of our team. And I thought what I could do is just quickly start, as you mentioned, with an intro, speak a little bit about our foundation's focus, highlight some of our work to date, and then really just speak about kind of why quality healthcare really does matter to the foundation, some of our priorities, and then some key questions of interest for our team that we have. So that's kind of what I would like to cover. I'll try to run through it fairly quickly, but again, thank you very much for including us in the conversation. I'm Katherine Wales, and I'm a Senior Philanthropy Portfolio Lead at Medtronic Foundation. We at the Foundation are really focused on strategies that enable the greatest leverage of health outcomes and health resources for key diseases and services, really for underserved populations. I sit on the global health team at Medtronic Foundation. We do have a much larger team that's also focused on things like volunteering and employee engagement, disaster relief, things like that. So I'm really glad to be here as part of a group that's really focused on developing robust, practical solutions to the quality conversation. I think all of us here on this conversation really understand that the quality conversation is the holy grail of healthcare, but it's super difficult to align stakeholders, to collect meaningful data, to really understand what's working. And without a real focus on quality and consensus on even what quality means, high-quality, cost-effective healthcare really doesn't stand a chance of scaling. And I think while we all recognize that RCTs are really the best way, the gold standard of achieving quality and measuring quality, we do really need healthcare advancements faster and in a lower-cost manner. I think we also, a number of us are agreeing and looking forward to a world where universal health coverage is really a part of the conversation. But without the conversation about quality like we're having today, and without a true intent to really think differently, we really don't want to be compromising on high-quality services to meet these goals. And then finally, also recognizing that the conversation about quality isn't just across clinical disciplines, but also across community health, social determinants of health, and a wider range. So really glad to be here, and this conversation is an important step in this larger direction. So just quickly, Medtronic Foundation overall you're probably familiar with the company, which is a global leader in medical technologies, services, and solutions. As the foundation, we're really focused on expanding access to healthcare for underserved populations and really supporting healthy communities in which we live and give. Our team is really focused on results-driven partnerships. We have an emphasis on strengthening health systems through leveraging frontline health workers, empowering underserved patients, advancing policy, and fostering partnerships. And a key piece and maybe differentiator of us in our work is really around meaningful inclusion of patients in all conversations. So not just viewing patients at the center of care, but actually hearing from them in the center. Also for the foundation, equity is paramount, which means really understanding what the right mix of services at the right place, right time, and right level of quality for some of these key conditions really is. And then a core piece of our efforts is really around scale and sustainability. So we all know that there are vast healthcare needs out there. There's limited resources, and how can we collectively and individually work to really unlock additional resources and broader health outcomes for a lot of these key things. So that's a quick overview of who we are. Some of our work to date, largely the foundation over the last few years on the global health side has been focused on these signature efforts. These are largely multi-year, multi-stakeholder, multi-country initiatives that are really working closely with communities to almost redesign how healthcare is delivered to improve health outcomes. There's a sharp eye towards testing, measuring, and disseminating evidence to ultimately drive policy and healthcare delivery improvement. So we have 3 of these signature programs to date. These are largely, I would say, 75% of the way complete, and we are excited to start getting more evidence and information in that we can use to, really drive key conversations. The first is called Health Rise. This is really focused on improving the detection, management, and control of cardiovascular disease and diabetes in the U.S., Brazil, India, and South Africa. And we started with key needs assessments in these communities to understand really what are the big barriers in accessing care and improving health outcomes, looking across things like supply chain disruptions, long distances to diagnostics, monitoring, key cultural and linguistic barriers. And then each community actually was responsible for implementing and designing different interventions, and we have a very strong evaluation partner that's been paired up to really understand from a qualitative and quantitative perspective what's been working and why has it been working. And so some of these interventions are really around empowering patients, empowering communities in self-management, care navigation, and addressing social determinants, and also really a focus on strengthening frontline health workers along with advancing key policy conversations. Our second program is Heart Rescue. This has been around a little bit longer. It is really focused on improving acute cardiovascular disease outcomes. We started in the U.S., are in roughly half the U.S. states now, and are expanding to Brazil, India, and China. Heart Rescue partners kind of more towards an integrated community response, coordinating public and professional education about acute cardiac events, looking at and introducing best practice treatments, and also helping with hospitals to implement and measure for improved STEMI performance and outcomes. It's also really about local ownership and includes a multi-sectoral stakeholder group like governments, medical professional societies, healthcare providers, patients, and families. So really kind of cross-sectoral. And then our last signature is called RHD Action. This is really focused on improving premature mortality from rheumatic heart disease, largely in Uganda and Tanzania, and working with kind of a cross-sector of actors to establish a scientific and technical support community so that other countries can draw on this technical knowledge to both advocate for policy change and support and empower individuals living with RHD. So those are our 3 signatures. I think what's unique about them and kind of the theme across all is that there's really strong local partnership, government, and patient participation in all 3 of those. We also really value strong evaluation partners that both conduct qualitative and quantitative evaluation for publication and cross-sector learning. And then, of course, there's an opportunity to really be testing novel healthcare system interactions. So as I mentioned, those are all about 75% of the way through, and we are really looking forward to the next coming years to get that information and really help disseminate it, especially given that we're in a world where there's not a lot of evidence around what is working and how do you actually scale it in a cost-effective way. So kind of just jumping to the quality conversation and why this matters, I think as all of you in the room probably agree, we're at a really interesting time where there is a significant rise in non-communicable disease. Of course, we know, everyone knows that it's important. Countries recognize that it's of long-term importance, but in the short term, largely most haven't allocated funding or really adapted health systems to better address these needs. And then in parallel, there's not really clear evidence about the right way to deliver high-quality, cost-effective care for NCDs. You're seeing a lot of pilots, few at scale, and it's really hard to compare results across. We urgently need effective healthcare solutions quickly, but we also really want to make sure that they're the right high-quality solutions. And so I think just in closing, some key questions for us that are things that are on our team's mind that we'd love to see if they resonate with others in the room are really around how do we ensure that quality is considered in the universal health coverage agenda? What does value-based healthcare look like for underserved populations? What are models of care that we can emulate, and how do they measure quality? What aspects of quality measure the most in primary care and with healthcare worker-provided solutions? How do you balance clinical quality measures and patient quality measures, which may be very different in our traditionally siloed fields? How do you measure healthcare quality in a cost-effective, meaningful way? Are there key measures or indicators that we should be looking for along the way that might be important red flags before key quality indicators are missed? How do we really ensure that patients and frontline health workers who see the impact of quality every day are really a voice in this conversation from the start and throughout? And how can we really align funders, government officials, clinicians, and patients so that we all agree on the same quality measures, and that when we finally land on something around what does quality mean, that we all actually will take it and implement it going forward. So those are just some talking points from my team and representing Medtronic Foundation's viewpoint, but looking forward to this larger discussion, and thanks again for including us.
Thank you very much, Anne.